Good evening, everybody. Can everybody hear me okay? All right, great. I'm going to wait probably one or two more minutes. I know folks are still checking in, and then we'll go ahead and get started. We're really excited to be here tonight and give you some information about the Autism Center. So stay tuned for just another minute or two, and we'll get started in just a moment. Okay, so I'm going to go ahead and get started. My name is Dr. Jody Camps. I'm a clinical psychologist at the Autism Center within the Department of Psychology at Children's Hospital. I'm here along with my colleagues and going to introduce each of them briefly. I want to give a brief overview for tonight's presentation, but in general, we're really excited to be here and happy to share information about our program and hopefully provide you with some helpful information about the services we offer, along with how to refer to us to access those services. So going to do a quick introduction. Everybody else, when it's their turn, we're all going to take some turns speaking. They'll also introduce themselves. So again, my name is Dr. Jody Camps. I'm not sure how folks are showing up on other people's screens, but we have Dr. Corin Boggs, if you want to wave, Dr. Corinne Johnson here, Dr. Farah Golmariami, Dr. Sarah Miller, and then Dr. Susan Fielko. And so again, each of us is going to take a turn speaking, so you'll get to hear a little bit from each of us. Again, the agenda for this evening is to provide an overview of some of the services we offer, along with give you some specifics about how to refer for those services. We have received some questions in advance, so we're happy to answer those. And then if questions do come up, I'm going to ask that you use the Q&A function in the Zoom meeting, and we will try to get to those questions at the end of the presentation. A couple of other housekeeping issues. We do have our behavioral health clinical program manager in attendance. Her name is Dominique Burns. And for those of us, or for those of you who are registered and we have email addresses, she will be sharing a copy of the presentation to you. So you will get some of this information sent to you. The presentation is also being recorded, and I believe it'll be available on the website. So for those of you who want to go back and access some of the information, you should be able to do that pretty soon. Next slide, please. Okay, so just to start with a quick overview of services. In general, we provide evaluation activities and treatment activities. Those are provided by a number of psychologists here in the program. We've been fortunate to have the recent addition of a developmental and behavioral pediatrician, Dr. Fielko. And so she's also providing evaluation and treatment activities along with medication management. And she'll be able to give you some more details about some of the specifics in terms of services she offers too. But in general, we like to conceptualize the services that we offer into two broad categories, so evaluation and treatment. And now I'm going to pass things over to Dr. Sarah Miller, who's going to provide a little bit of an overview about autism spectrum disorder.
All right, hi. So even though I'm sure most of you attending are familiar with autism, we feel like it's always helpful to give sort of a brief recap of the main highlights related to the diagnostic criteria, because that I think is often really helpful in determining when to refer patients over to us and also understanding our diagnostic decisions. So for autism spectrum disorder, or ASD, the symptoms show up in two main areas. The first area is difficulties with social communication. So this is not just language, but it's all the other things that go into a back and forth interaction. So there's 3 different areas that difficulties show up in social communication. There's problems with back and forth communication or conversation. This can look very different across different kids depending on their developmental and cognitive skills. So it could be something like maybe having no response to their name being called at all, or maybe an inconsistent response to their name. That could be something that shows up in a very young child. For a child who maybe doesn't have as many developmental or cognitive delays, you might not see quite as stark of a difficulty with response to name, but you might see that they have problems keeping that back and forth conversation going. It's very one-sided. They're talking on and on about their own interests, and they're missing social cues that other people are wanting to talk or contribute, or maybe that other people are not interested or not liking what they're talking about. Another area we see difficulties with social communication is in the nonverbal behaviors that contribute to maintaining an interaction. So these are differences in eye contact, use of gestures, or facial expressions. That word difference is important because I think kind of traditionally there's been the thought like, oh, if they make eye contact at all, they don't have autism. But what we understand now is that people who have autism sometimes do make eye contact, they just don't make it as flexibly and as frequently as we would expect. So eye contact or use of gestures could be totally absent, or it could be that it's not very well integrated with their speech. So maybe they're talking and they're gesturing, but they're not looking at you, or they're really briefly glancing at you and then looking all around. So they're not able to sustain the eye contact. So that kind of differences there is important. The other thing you can see is difficulties with reading other people's nonverbal cues related to their gestures or facial expressions. And this kind of leads into that third area for social communication, which is difficulty understanding relationships and making and keeping friends. So again, this can really present in a wide array of things. It could be simply not being interested in other children at all, which I think is kind of the more traditional understanding of autistic disorder under the DSM-4, where, you know, it's the child who's kind of maybe off in the corner playing by themselves. However, we can also see difficulties with making and keeping friends showing up where maybe the child is very interested in social interaction, but they're having difficulty successfully interacting. So they come on too strong, they barge into the play, they don't notice that the other kids are upset that now they've disrupted their game. And so it could be that, you know, maybe they're trying to join, but they're standing on the outskirts and they're not really noticing that they're not actually participating, because just since they're physically near, they think they're participating. So those are some ways you can see the differences in relationships showing up, that difficulty with making friends. You can also see it in play behaviors. So we know for very young children, the way they play is part of how they develop their understanding of relationships and relating to other people. So you might see that they play with toys not in the way they're designed, or that they play with toys in the exact same way, or that they have trouble playing with other people. So maybe they have their things they like to do with their play, but when mom or dad or sister tries to join in, they get very upset about them kind of disrupting the way they were planning to play. So those are kind of those areas for social communication. The other big core area for autism spectrum disorder is repetitive behaviors or interest. So there's 4 main areas that symptoms show up in, and again, a very wide array of how these symptoms can show up, which is part of what makes it so complicated. So the first area is unusual or repetitive behaviors that they do with their body or with their speech. So again, the kind of more obvious ones might be rocking back and forth or side to side, flapping their hands, spinning in circles. Could be things like kind of posturing their hands, holding them in slightly different ways, echoing other people's speech, or repeating things that they've heard before. So quoting things from a movie, not in part of a conversation and an interaction, but just sort of quoting it to themselves afterwards. The other thing you can see is difficulties with changes in routine or schedules or expectations. So the way the diagnostic criteria talks about it is an insistence on sameness, right? We know that all children do well with routine, but for a child with autism, the amount of time it takes them to recover from a change in routine is drastically different than for a child without autism. So that's where that insistence comes on. You can see insistence and sameness showing up in their eating habits. Maybe they only eat certain brands of foods, or maybe they refuse foods if they look imperfect. If the cracker is broken, they won't eat it. So those are ways you can see that kind of selective eating, refusing foods that look a certain way or whole groups of foods. And then also just refusing sort of broadly things that are different, right? So not being able to kind of flexibly respond whenever there's a slight change in the expectation. The third area is differences in their interest. So there's kind of two ways this shows up. One is being sort of fascinated with things that would not be expected for their age. So maybe a very young child knowing everything about World War II or something like that, something that seems really advanced for their age, where they're talking about it on and reading all about it. Or it could be that they're interested in something that's maybe age appropriate, but to a very extreme degree, such that it causes problems in the family life. So, you know, the child who maybe has their favorite toy that they have to bring everywhere with them, and they're having a complete inability to tolerate leaving it at home when they go to school or something like that. Again, this would be sort of outside of what might be developmentally expected of when kids get little attachments to different things. This would be a more extreme version of that. And then the fourth area that we see symptoms is sensory differences. This is a really important new addition under the DSM-5 to the diagnosis of autism. So previously, sensory differences were not part of the diagnostic criteria, but now we understand that that is part of the autism diagnosis. So kids can be either overreactive or underreactive to sensory information. If they're overreactive, that's sensitivity to sounds, sensitivity to lights, you know, covering their ears when daily sounds like a toilet flushing or a blender goes off. Or if they're undersensitive to sensory information, they might be very sensory seeking, rubbing things on their face like toys that you wouldn't expect, mouthing much longer than you would expect a child developmentally to mouth, or sniffing things that you wouldn't be expected to have a smell, listening to sounds over and over again. Those are all some of those sensory differences that might, you know, flag you to think about autism for a child. So I've mentioned a lot the DSM-5 and the DSM-4. That is the book that we use to diagnose as providers looking at autism spectrum disorder. And when the DSM-5 came out and combined autism spectrum disorder, it took away diagnoses like Asperger's disorder or PDD-NOS and autistic disorder, combined them all into autism spectrum disorder, understanding that these are all the same core presentation, just the specific way that it looks for different children looks slightly different. So the way we classify the different presentations is using a level to talk about the level of support that the child needs from other people to kind of get through their day-to-day life. This is how many symptoms you're seeing, how often you're seeing them, how hard they are to interrupt or redirect whenever they happen. There's 3 levels. Level 1, which is requires support. Level 2 is substantial support. And level 3 is very substantial support. So while it's not a perfect correlation, level 1 would be more similar to what would have been thought of as Asperger's or sometimes maybe PDD-NOS, and level 3 would be more similar to what would have been called autistic disorder under the DSM-4. So I think that's sometimes a helpful explanation that I use with parents sometimes when they're confused why their child is being diagnosed with autism and not Asperger's. So now that we've kind of had that little recap, I'm going to kick it over to Dr. Filko, and she's going to talk a little bit more about some of the things we know about autism.
Sorry, forgot about the microphone. Hi, everyone. I'm Dr. Susan Filko. I am a board-certified developmental behavioral pediatrician, but I was a general pediatrician for over 20 years before I went into this subspecialty. So I think I'm so happy to be part of a team dealing with children with autism, but I'm going to give you a little bit more from the physician perspective that I think might be important to your practice. So first of all, the American Academy of Pediatrics wants us all to know that autism is not rare. And actually now 1 in 54 children are diagnosed on the autism spectrum. I had the opportunity to listen to a webinar yesterday on science and autism, and they talked about this number seeming to be almost like an epidemic, and it's so high. And actually, one of the perspectives that was presented was this is about 2%. And when we think about it, many disorders defined in medicine fall into that small percentage of about 2% to fall out of the normal range of distribution. And we think about it, that's not so surprising when it comes to developmental differences as well. And we certainly have increased our recognition among all socioeconomic and ethnic areas. And so that also helps with our broadening of our recognition. Other important facts are autism spectrum is 4 times more likely in boys than girls. Many developmental problems are more frequent in boys as a rule. And then I think that one of the really important facts is that autism can be diagnosed comfortably as early as 18 months of age. So very often we get referrals rather late, and I'll do my little finger wave now because we don't want that. The earlier this can be diagnosed, the earlier we can intervene, the more likely there will be a substantial difference made. So don't be afraid to make referrals. As pediatricians, we tend to do a lot of reassuring. Things are going to get better. The cold is going to get better. The fever is going to go away. And we reassure and reassure. When it comes to developmental disorders, reassurance is not the way to do things. Instead, it's to make early identification and provide the interventions that are necessary in order to change its trajectory of the developmental concern. All right. I don't think I have to go into a lot of detail here because Dr. Miller went through this very, very well, but some of the early signs, and we think of this developmentally, are when the child's social and communication skills are falling out of what we expect to be typical. And if we think of this developmentally early on, between 6 to 8 months of age, children make excellent eye contact even earlier, and they do what's called gaze monitoring. You're looking, you're playing peekaboo and coochie-coo, and then you go to look away and your baby looks with you. It's just a remarkable thing. Soon after that, you're pointing to stuff. Hey, you know, you're naming things in the environment, and your baby then realizes this little digit is attached to you, and they look at it and they look back at you and they share that observations as you think you're teaching them to talk. And soon afterwards, they learn how to use this implement. They point, and again, with reciprocal eye contact, and respond to your name and social requests. And by 14, 15 months of age, they're starting to share observations with you, pointing to the airplane and wanting you to see what they see, and finding a stick and giving you a stick. So all of those social communication behaviors are developmental, and they correlate well with the child's cognitive abilities. Along with that are the variety of restrictive repetitive behaviors. Dr. Miller went into that in great detail. One of the most important things for a primary care physician to recognize is when there's regression. So when there are well-established language and communication skills that sort of disappear, and parents will describe this as like the light went off and the child woke up and was different. It doesn't mean they were going da, 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 and then they stopped doing that. There are other reasons for that, but I'm talking significant, they had clear words and social communication skills that disappeared. Those need as quick a referral as possible, and they could represent some more significant medical problem. So we will try to get them in as soon as possible when you see those. Okay, so evaluation. The evaluation is a behavioral assessment. So I do a lot of developmental testing, which is sort of skills testing. Make this many blocks, make this design, do this thing. This is not that. This is looking at social and communication behaviors in a semi-structured way. And we have ways to do this. There are many instruments. The ADOS is the classic tool, but we have ways to do this virtually where we can make those observations that look at the child's social and communication behaviors. We look at not only what behaviors are being exhibited, but what behaviors are absent that we would expect that child to be exhibiting as well as some of those atypical behaviors we've already covered. Okay, so this is where this is important. So the American Academy of Pediatrics, as you all, I'm sure know, highly recommends, if not mandates, that primary care providers do surveillance and screening. What does that mean? Screening is meaning you use a specific validated screening tool to assess a child's development, including social communication skills. Surveillance means at any visit that a parent brings up a concern or you have a concern, you need to do something more. So these are really important. In the old days, we had our little mental checkoff list. We asked a few questions. It has been well proven that as smart as we all may be, we ain't that smart. That we really, those standardized tools are much better at identifying developmental concerns than our checkoff lists. And one of the most important ones that we use, I like the ones at the top. There are a variety that are accessible, but the MCHAT Revised, that's the newer version, is probably the easiest thing for primary care physicians to use. And there's even access to something called follow-up questions, because sometimes you'll get things rated and you may want to delve into it. I think one of the classic examples is, you know, does your child make eye contact? And parents sometimes struggle with that. And then often I hear them say, well, when I scold them, they don't look at me, they avoid looking at me. Well, yes, that is true. That is a defensive behavior that most people do. This is when we're talking about social behaviors, making requests or engaging others. How is eye contact? So I highly recommend you use one of these tools, probably the MCHAT, at every one of your 18 and 24 month or maybe 30-month visits to ensure there are no symptoms. For older kids, it's a little more complicated. There are some tools available. Most of these are not free. Many pediatricians use the PEDS. It does have social communication questions. I happen to like the SCQ. I think you have to buy those, but those are for individuals who want to really screen for older children who might have these types of concerns. Okay, so now I'm going to turn it over to Dr. Boggs.
Hello, thank you so much, Dr. Fielko. I'm Dr. Corin Boggs. I am a psychologist here in the Autism Center at Children's. I am also, full disclosure, going through the slides. So if you see me looking around, it's because I'm making sure that I'm clicking appropriately. So I'm driving and talking at the same time, which I wouldn't recommend in real life, but in PowerPoint, it's okay. So it's nice to speak with you all today. I'm going to talk a little bit about our evaluation services specifically. I know that's one of the primary areas of concern and one of the reasons that folks refer to us. So I want to talk a little about that. Our model here is to provide comprehensive diagnostic evaluations for autism spectrum disorder. I'll talk a little more in detail about what that means. There is a deliberate reason why we provide the comprehensive diagnostic evaluations, which do involve gathering more information than just kind of observing a child over the course of an interaction with a parent, for example. And to gather the information that we need to really make up the comprehensive diagnostic evaluation, we do that over the course of a couple of visits. It kind of depends. Sometimes it's 2, sometimes it's 3. For older children, it's 3. For younger children, it could be 2 or 3, kind of depending. The evaluations always begin with a clinical interview, which is when obviously we gather information about the history, developmental history. For older children, it's really important that we get information on things that may have been present early on, even if they weren't super clear at the time. We kind of want to know how kids develop socially, if they had, were kind of doing okay, and then things sort of fell apart when they went to kindergarten, which happens, or started school. We get a, thorough developmental history, biopsychosocial stuff, intervention history, all of those things during our clinical interview. The testing appointment is the next appointment. It sort of depends. For younger kids, sometimes that's part of the first appointment. For some kids, it's the second appointment. And this is when we're administering the standardized measures that are required as part of a comprehensive diagnostic evaluation, really in order to obviously inform the diagnostic decision, but also to make sure that kids are able to access appropriate services after the evaluation. And we'll talk about that again some more, but it's an incredibly important point to make. The third appointment, at some point in time, whether it's a third appointment or the second, the last appointment that we offer families as part of the evaluation process is what we call comprehensive feedback, which is really an opportunity for us to go over the diagnostic impressions, let the parents know kind of how we came to those conclusions, and then also really start to talk with them about recommendations, next steps, who else to go to, where to go. You know, if folks haven't been hooked up with early steps and they're very young, we're going to make that recommendation. If they're over 3 and they haven't been looked at by the school, we're going to help parents figure out how to get that started. We provide parents information about the early steps, the system point of entry, the school districts, and how to request information. We give parents information on resources in the community, like Families Helping Families specifically. All of this information, I'm not sure if it's on this slide or on another slide, all of the information that we gather is collected into a report that is part of the medical record. Anybody that has Epic is able to access that, and we've been using Epic for a few years now and send reports through Epic. So as primary care physicians, if you send us a child for evaluation, we will send you notification when we're finished, and we'll send you the report, and we'll send you a letter with our conclusions, and you'll have access to that information in the record. In terms of the testing procedures, in order to make it a comprehensive diagnostic evaluation, we always do measures of developmental or cognitive functioning. Partially, it's to make sure that we kind of check that box off and assess that area of functioning. The other piece is, I think like Dr. Fielkow mentioned before, and like Dr. Miller mentioned before, when we're looking at symptoms, we want to make sure that we're also comparing what we see socially to the child's developmental level. So we're looking for the best way to account for the things that we're seeing. And we want to make sure if we're seeing, you know, kind of delays or impairments socially, are those consistent with the developmental level, or is it different? Are they developmentally okay in terms of motor stuff and cognitive stuff, but socially behind? That's very different from being socially behind and behind in all of the other areas as well. So in order to have that kind of anchor and benchmark, we do assess developmental functioning. For older kids, we're assessing cognitive functioning, adaptive functioning, which is the obviously daily living stuff. These measures in particular are critical for accessing supports and services after the evaluation. So for folks who may need to register with the Office for Citizens with Developmental Disabilities or any state services, or families who might need or benefit from supplemental income, the measures, the scores on these measures are required. It's critical. It's a critical component of the evaluation. We're also looking at behavioral functioning, and then ASD symptoms using semi-structured observation. In a perfect world, when we don't have to wear PPE. Prior to COVID, we were doing the ADOS-2, which is the gold standard instrument used for the semi-structured observation piece of autism symptoms. I'll talk about this a little bit. I think it's on another slide too. We're currently using the CARS-2 as our rating form. It allows us to collect observations and provide the ratings in a standardized format. The ADOS-2 currently cannot be administered in its standardized format with PPE. It's not normed for use with masks and face shields and all the other things that go into seeing folks in person. And it's also not suitable for administration virtually. In terms of the comprehensive feedback, I think I talked about this a little bit, got ahead of myself. We review the diagnosis with the family, treatment recommendations, community resources, and we also start to talk about strategies for managing specific concerns. It's really important to us that families are able to access the kinds of support as early as possible to manage the things that are getting in the way of life. We talk with families about toileting concerns, sleep problems, feeding challenges, things that all tend to be more common for kids on the spectrum. We also really talk about accessing applied behavior analysis, behaviorally based intervention as early as possible, as we know that is one of the things that changes developmental trajectories if it's provided and caught early. So it's kind of another reason to be very vigilant and refer as soon as there's concern as opposed to waiting to see. There's really not any drawback to doing an evaluation early and starting early intervention. At worst case scenario, if a child doesn't truly meet criteria, they're getting support in the areas where they're struggling, and it's changing their developmental trajectory and providing them with support. Okay, so I talked about this a little, but I'll review it. Why a comprehensive diagnostic evaluation? So, this most importantly, when folks are going through the diagnostic process, our goal is to make sure that families are able to access the services and supports that their child needs. And according to Louisiana Medicaid guidelines, there is a specific definition of what constitutes a comprehensive diagnostic evaluation, and that is required for folks to access ABA, for ABA to be considered medically necessary. So it's really important to have those components, even for kids who might be very clear. There are certainly kids that we see and we kind of see them pretty quickly, and maybe, in the waiting room, we see signs and symptoms. It looks pretty obvious. The parents give us a history, and then pretty quickly it seems apparent that the diagnosis is really appropriate. But just saying my clinical opinion will not be enough to get a child services. So in order to justify the recommendations, in order to make sure that families are able to access services quickly, it's really important to have all the parts and pieces of that comprehensive diagnostic evaluation. If not, if we just say, yep, we think it's autism, and we don't have those parts and pieces, then the child may go on another waiting list somewhere else to get additional evaluation to determine disability eligibility. They may not be able to access ABA, for example. So it is really important that children are getting the actual formal comprehensive diagnostic evaluation, children and adolescents. I think we may have talked about this before. I don't know if I saw it on a previous slide, but the age range of our evaluations that we serve, we do serve children age 18 months to 21 years, or individuals up through age 21. So we do see older teenagers and young adults as well up to that age for diagnostic evaluations. The other thing, just for primary care folks that are in the audience, sometimes when kids are trying to access, or families are trying to access ABA services, there are occasionally requests for like a prescription in addition to our recommendation for ABA. And our hope is that when we provide this report to you, at the end of the evaluation, it makes it easy for you to use that documentation and kind of quickly provide a prescription if that's required for ABA. So there are some agencies that the criteria kind of differ agency to agency. It's not the Medicaid guidelines don't really specify that it has to be a formal prescription. It has to be formally recommended as part of the CDE, which is what we do. But there are some agencies that do require a formal prescription. And if so, we want to make sure that our reports serve as communication to you that makes it easy to make that recommendation if a family comes back to you with the diagnosis. Some changes during COVID. The first thing that we're super proud of that we developed last year is what we call our REACH clinic, which stands for Remote Evaluations for Autism at Children's Hospital. The REACH clinic is an all virtual model that persists today. We do not expect this to go away. I think this has lots of benefits beyond the pandemic. It has been extraordinarily helpful in being able to provide services to very young children over the course of the last year. So there weren't significant gaps in care, and those young kids were not waiting an extra long period of time. The model is appropriate for young children and children with limited speech. So we're able to assess kids usually up to and through age 3 and sometimes older, depending upon their functioning level and what sorts of tests are required. If we have to do formal cognitive testing, that has to be done in person. But a lot of the other pieces can be done virtually. So this initially was developed in response to the pandemic. This has also been very beneficial for our population. I see this extending beyond this since we serve the entire state of Louisiana. This allows folks who live farther away to be able to access this care and this service without having the burden of needing to travel 5 or 6 hours for multiple visits and appointments. We did, when we developed the clinic, modify the test selection consistent with best practices. I talked a little bit about this before. The ADOS cannot be administered virtually, and it cannot be administered with PPE. So we are using the CARS-2. There's an instrument that's called the Tele ASD Peds. If anybody is super interested in learning more about it, it's from Vanderbilt. The folks there have developed this very useful tool to help structure observations virtually. So it gives us a chance to coach parents through doing some of the things that we might do or would do if we were able to see the kids in person. So we kind of have the parents set up and do things in specific ways, and we ask the parents to try and get eye contact and play with the kids and point to things and kind of see how they respond to their name and things that we would do if they were in person. And then the CARS is what we use as our rating scale to rate the observations and inform our decisions. Also, as a result of COVID, and then this I think will persist as well, we do have a hybrid model that allows for virtual and in-person appointments. This is for all ages. This is, again, I mentioned a little bit before, if we need to do cognitive testing, they do have to come in person for that. But this is a model that I expect will continue as well. And again, for the same reasons we mentioned to right now, obviously related to exposure. But moving forward, I think this will be really helpful for families who do have to travel. They will only have to travel for one appointment. We can provide the rest of the care virtually. And now I will pass on to Dr. Johnson for the overview of the services treatment.
Alrighty, so hi, I am Corinne Johnson. I'm another one of the psychologists here at the Autism Center. So I'm going to talk to you guys a little bit briefly about our treatment options. So one of the treatment services that we have is an individual model, and that's more toward either a specific child, but really the child and their family. So in terms of short term, that just means that we're not going to see the families forever and ever and ever. With our kids, they might need some assistance forever and ever, but our goal is to kind of teach the parents some skills, something that they need right now, and to teach them how to keep things going so they won't necessarily need us forever in terms of that service. And then for Dr. Fielko, she can also do some following up with them in the future if they continue to need somebody to follow them more extensively. And then our hope also is that if they do have more severe symptoms affecting them in terms of autism, or they are younger little people, they're also getting some additional services outside of us. So they're still getting, like everyone has talked about already, ABA services. Family focused, what we know for autism is it's best if families are involved. So we're not seeing the child in isolation, we're involving their parents and helping the parents learn and practice the things with the children as well. So these services, one of the great things about them is families can access them while they're waiting for an evaluation. So I know we hear things about how our wait list is long, and it is long. They're kind of long everywhere. And in the meantime, we're able to, if families are interested, they can be put on the wait list for this, and we could possibly see them sooner, even before their evaluation, as long as somebody has some concern that there's autism spectrum disorder. So that kind of helps with that aspect of things. So this is one way that we can access people while they're waiting for things, and then also after they've already had that evaluation. So that's kind of this individual service that we have. The other kind of services that we have are group services. So both of them right now are on hold during COVID, but we are working on some ways to kind of get them started back up soon. Similar to how we made that REACH model, thinking about some kind of flexible ways that we can make our services happen. So one of them is parent training workshops. And this is also something that people are able to access while they're waiting for services and if they've already had a diagnosis. And the diagnosis, something else that we should kind of highlight, even though we're the Autism Center, it doesn't just have to be autism. So if the child has developmental delays, if the child has intellectual disabilities, somebody's suspecting autism or they have autism, then they're able to access these things as well. So the parent training workshops are on things that affect a lot of our kids: toilet training, helping the parents with getting them to communicate more, talking, what to do when there's some behavior challenges, sleep problems, feeding problems. So things that are affecting a lot of our families. This is the way that we're able to, in this one time, give them all this information that they're able to take out of here and away, and not, again, necessarily needing us all the time or every week. And then social skills groups, we offer those for children who are verbal and they're 4 and up, and they're able to learn in a group format. So this is an evidence-based service. That means that it has some evidence of working. Our parents and the children are, again, involved. And like I said, it's on hold right now, but we're also working on some flexible ways to treat those families. So this is something that's helpful for a lot of our kids who are, the ones that are a little harder to spot. Like, they can talk and they can look at you and they're able to have conversations, but maybe the conversations aren't the best, or they're really having a hard time making and keeping friends. And that's the purpose of these groups. And then Dr. Fielko will take us away with what she's doing in terms of developmental behavioral pediatrics.
Yes, happy to do that. So I often think of developmental behavioral pediatrics as sort of the developmental medical home. In pediatrics, we talk about the pediatric medical home, sort of the, I don't know, quarterbacking, coordination of care person. So my role will be helping the families navigate the systems. It's very complicated. Psychologists do a lot of work in that area when the first diagnoses are made, but sometimes there needs some ongoing hand-holding and assistance with that navigation. I also do things like assist with referrals to speech, occupational therapy, ABA. Over the lifespan, we can help with working with the IEP review and recommendations, and assistance with social services as time goes on. Families tend to hear all of this at once. I often, say it's kind of like the A-bomb. They hear it, and then some of the information goes in, and some gets lost soon after they hear the diagnosis. So we want to carry them through time to assist with things as needed and as they occur. The other thing that I assist with is coordination of medical care. So often children with developmental problems have comorbidities, so they might need assistance with neurology. I often refer to genetics or do some sort of genetic testing, and we coordinate care with regard to that or any other systems that might be involved. As time goes on, sometimes comorbid behavioral diagnoses occur. Things like ADHD, aggressive behaviors, anxiety, sleep disturbances, eating disorders, things like that. And I can certainly assist with the behavioral and medical management. So many things that I can assist the primary care physician with over the years. I can be a consultant, I can be a manager. I'm here to be an extension of your services. Having been a primary care provider for so many years, I know that time is very limited in the pediatric setting, and I can help you out wherever I can.
Okay, so I'm going to pick back up again and talk a little bit about details in terms of our referral process. Okay, so hopefully, I know several of our providers have mentioned Epic. Epic is the electronic medical record that we use, and we definitely prefer, if other providers have Epic, please send us referrals via Epic. You can refer directly to us, and so again, we wanted to have these details available to you. So it's CHNO ST Autism. And again, you want to specifically look for ambulatory referral to pediatric behavioral health psychology. You can enter a specific provider's name, but you do not necessarily need to do that. It is helpful for us. Oftentimes, the more information you can provide, even if it's something brief, is really helpful for us. So again, if you are wanting to refer a child for an initial diagnostic evaluation, if you can note that is really helpful. If you need to indicate maybe the child has a school evaluation, but they need a formal clinical diagnosis, or if you're thinking this may be an appropriate referral for parent training or treatment, that would also be helpful to know. Again, in general, the more information we have, the better, and the easier it is for us to get families routed to the right place. I did want to mention, I don't see that, but we will also accept referrals via other ways. So we will accept them through fax. Again, we prefer that it's through Epic, but we will accept them via other means as well. So here's a quick overview. I know some of my colleagues have mentioned this already, but who and when to refer, particularly for an initial evaluation. So obviously, for evaluation purposes, we are a specialty or subspecialty clinic, and our the main purpose of our evaluations is to determine, might this child be showing signs and symptoms of autism spectrum disorder. Again, I know my colleagues have mentioned this. We see children as young as 18 months, and we will go all the way up through age 21, so including young adults as well. Sometimes maybe a family has had another evaluation, but they are interested in a second opinion. That is also an appropriate time to refer to us, and we are happy to do that. Again, many times children that come to us may already have some services through school or may have an educational classification of autism or a different school classification. as many of my colleagues have already mentioned, this is helpful to get services in school, but is often not sufficient to get some of the longstanding services that are going to be really helpful for that child and family. So again, it is okay for us if a child has an educational classification of autism, but still needs a clinical diagnosis, that is also an appropriate time to refer. Now, I know sometimes we get requests for reevaluation, and I know my colleagues and I felt like it would be helpful to provide some clarification about when this might be appropriate. So sometimes I think it can be confusing. In general, autism spectrum disorder is considered to be chronic in nature. Sometimes children can make a really significant degree of progress, particularly if they've received early intervention. In general, though, because that autism spectrum disorder is considered to be chronic, we typically want there to be enough time for some of those intervention services to work. So our typical recommendation is, we want there to be at least 2 years after that initial evaluation. Sometimes, though, maybe you as the physician or the primary care provider feel like, gosh, this child, has really come, leaps and bounds, or has made a really significant degree of progress, and you think, gosh, I'm not sure that this diagnosis is still appropriate. That's fine. Please refer them, and we'll be happy to do a reevaluation in that case as well. Sometimes us as the initial provider, sometimes there are certain kids we want to see again. So I know that I definitely will document this in my recommendations. If there's a child where kind of in either direction, I'm going to call this autism spectrum disorder right now, but it's really pretty mild. And I think with the right type of intervention services, maybe this child will make enough progress that diagnosis is no longer appropriate. Again, I'd say that's the minority of kids, but we want to make sure that we can see those kids again to, continue to determine the appropriateness of a diagnosis. Sometimes maybe we see a child and we didn't make a diagnosis on the day that they came for the initial evaluation. And you say, you know what, I think we're still hearing kind of ongoing concerns about autism spectrum disorder. Absolutely. Because this diagnosis focuses on behavior, it is not 100% accurate. So by all means, if you have concerns as the provider or the primary care physician, by all means, if you're seeing these kids more frequently, definitely send them to us again if you think, I'm not quite sure, or things have changed. Another situation where we will be able to provide a reevaluation is sometimes, maybe a child's evaluation is considered expired, and it's making it difficult for them to continue to receive necessary services. And so again, in that case, we are happy. We want to make sure children continue to get the services that they need. So we are definitely happy to see those families again. Sometimes, though, I think what can happen, I know families will reach out to their primary care provider or physician, pediatrician, and say, oh, my child had a big meltdown in class today. I don't know what to do. Honestly, a reevaluation is probably not going to be helpful in that case. Ultimately, they need support, they need intervention. And so we are happy to work with you to make sure families are getting connected to the appropriate resources, but that would not be a good time to send for a reevaluation. So again, there's some judgment there. If you have questions or concerns, all of us are very willing to talk with providers, and you can say, hey, I'm not sure if this is an appropriate time to re-refer. Definitely reach out, and we will be happy to answer your questions the best we can. Okay, some information about treatment. So again, my colleagues mentioned this as well. So we provide treatment services for children both with a confirmed diagnosis of autism spectrum disorder. For children to access services here, they do not necessarily have to have been diagnosed by us. So if a child has a diagnosis from a different state, a different agency within New Orleans, a different agency in Louisiana, that is fine. We will be happy to see families. Again, as Dr. Johnson mentioned, we will also see families while they are waiting to get that clinical evaluation. So even if you have suspicions that they might have autism spectrum disorder, families, even in that situation, can access many of the services that we offer. Again, as Dr. Johnson mentioned, many of the services that we offer are also appropriate for children who either have intellectual disability or global developmental delay. So again, families can access services with those diagnoses as well, even if their child does not have autism spectrum disorder. So again, several people have commented, Unfortunately, it often takes a while to get that formal diagnostic evaluation. So we know there's a long wait, and we are constantly working as a team and as providers to try and find unique ways to improve access to services. So please know that we are aware that wait time is frustrating both for providers and families. I would say we're not unique. Most agencies in the state are in the same situation. In the meantime, though, I would say please be proactive. So again, several people have commented early intervention in this situation really is critical. So if a child is under 3, please refer for early steps. Early steps is available throughout the state. They can get kids going with lots of needed services, so speech therapy, occupational therapy, special instruction. Again, they can kind of get things rolling. They also do their own autism spectrum disorder screening. And again, it's kind of another piece of information that can be really important for families. If a child's older than 3, please refer them to an evaluation through the public school system. Again, that's another way for families to get access to services. You can also refer families to private speech and occupational therapy agencies, again, while some of these other services are getting into place. And lastly, please provide information to families. I'm going to turn things over momentarily to Dr. Golmariami, but there are lots of resources available that can be helpful both for providers and families. And so I'm going to kick things over to Dr. Golmariami, who can tell us a little bit about some of those resources, but please share information with families.
Thank you, Dr. Camps. Hi, I'm Dr. Farah Golmariami. I'm a postdoctoral fellow here at the Autism Center. So the first resources that we have that are available are for free and online. The ones that you see here are nationally available to everyone. Most of these resources focus on psychoeducation, so telling families about evidence-based treatment and things like that. Another helpful thing that some of these resources provide are toolkits. So for example, Autism Speaks provides many toolkits to family on resources on feeding concerns or toileting challenges that can often be helpful for families while they're waiting, or if they want quick tips before seeing someone on a more ongoing basis. The next resources are local, and these resources help put families in touch with local resources in their respective areas. For example, Families Helping Families offers peer-to-peer support to families. One of the things they might help out with is helping them reach out to find ABA agencies, or providing advocacy if a parent is trying to get an IEP and to navigate that process. The other resources that are available are books. The first that you'll see for younger children mainly focus on teaching language through and promoting play skills. These have lots of strategies that we use with our families and we teach our parents. So many tried and true tricks out there. And the second group for older children mostly focuses on social skills or teaching independent living skills. So next, we'll review some questions. Some of you submitted questions ahead of time, so I'm going to go ahead and read those, and my colleagues will answer them. One question that you had was, are services provided for Spanish-speaking families?
I'm happy to answer that one. Yes, we do provide services to families who require any kind of interpreter. So not just Spanish speaking, we are fortunate to be able to provide evaluations and treatment.
Thank you, Dr. Miller. Another question we had was, do immigrant families have to apply for CHAP financial assistance program for services to be covered?
I can take that one. So we do have a financial assistance office and financial counseling services available. There is some information available on the main children's website. So if you go enter financial assistance in the search, the policy, both kind of the formal policy and the policy in lay language, is available in multiple languages, including English, Spanish, and Vietnamese. We actually don't do a whole lot directly with the financial piece. So my recommendation would be to have families contact the financial counseling services number directly, or and so again, that phone number is also available on the website.
Thank you, Dr. Camps. The last question we had is, are services provided at other locations that are affiliated with Genoa?
Does someone, I can take that one as well. So not at this time. So the in-person services that we offer are housed here. We are located on the State Street campus, right across from the main hospital. The beauty of telehealth, though, is that many of the services that we offer, including those intervention services, so the parent workshops, the short-term parent family consultation, that's all available through telehealth or telemedicine. And so again, I know my providers are really excited. It allows us to have a wider reach. And so as long as families have access to a phone and internet service, then yes, we are able to work with them wherever they're located. They do have to be physically located in the state of Louisiana. So that's a requirement specific to our licensure. But other than that, we can see them regardless of wherever they are within Louisiana. And I saw somebody had raised their hand. I don't know if you can type your question in the Q&A. I think that was from like,
oh, it's gone now.
Oh.
My hand is gone.
Are there any other questions at this point in time? Again, we have a few minutes left. We're happy to answer any questions live as they come up. Oh, all right. If things do come up, again, we will have all of this information available on the website. And for those of you where we have email addresses, we will also be sending you information, so you'll have access to some of it in writing. Again, please feel free to reach out to any of us. I know my colleagues and I, we're happy to get folks pointed in the right direction and answer questions, but we really do appreciate the opportunity to speak with y'all and share some information about what we're doing. So we hope this was helpful and appreciate your time tonight.